Welcome to HealthFirst, Top Doctors podcast. Today we're discussing RCPD with Mr Chadwan Al Yaghchi, leading consultant laryngologist and ear, nose and throat surgeon in London. So how are you, Mr Al Yaghchi?
Hi, Caroline. Thank you very much for having me. I'm all right, not too bad. Just start to the year, recovering from a bad flu. It seems to be going around everyone. So if my voice goes a bit, so that's why. So, but I'm at the end of it, so it's all good. Thank you.
No problem. Well, thank you so much for joining us today. It's such a pleasure to speak to you. So could you tell us more about yourself and your work?
So as you kindly said, I'm a laryngologist. So laryngologist, I'm an ear, nose and throat surgeon by background, but I'm a laryngologist, which is a specialist in all things larynx. Larynx is our voice box. So it's a little bit beyond the voice box. So everything related to the throat, really. So our laryngology, we manage three areas. So we manage voice issues. So all voice disorder, hoarseness, vocal cord paralysis, etc. We manage dysphagia, which is swallowing disorders, and we manage airway symptoms. And by airway symptoms could be airway narrowing of the airway, which is the area I focus on in my NHS practice, but also other irritable condition, chronic cough, laryngeal spasm, vocal cord dysfunction. That's all falls under the umbrella of airway. So this is in general what modern laryngology practice looks like. And I cover the full breadth of laryngology in my practice.
Wow, that's a lot, really multifaceted.
Thank you.
Fantastic. Okay, so let's get started with the questions. So, what is RCPD?
So RCPD is an acronym for Retrograde cricopharyngeus dysphagia, a bit of a mouthful if you say the whole thing. So RCPD, so let's start with cricopharyngeus. So the cricopharyngeus is a muscle, sits at the top of the esophagus. So esophagus is our food pipe. In the throat, our breathing tube and our swallowing tube are connected. And the function of the voice box is to protect the airway, so it closes as we swallow, and then food goes down into the esophagus. At the top of the esophagus, we have the cricopharyngeus muscle. So this is semicircular muscle that is always closed, which means it keeps the esophagus closed. So if reflux, if gas, if fluid comes up into the esophagus, there is that protective mechanism. So it closed. It doesn't allow things to go into the airway, get aspirated. So that's the cricopharyngeus muscle. It's, as I said, it's closed all the time. It opens up as we swallow, and that's the anterograde. So when we swallow, food goes down, muscle relax, food goes into the esophagus, it closes again. Now, retrograde means in the opposite direction. So the cricopharyngeus muscle also open as we burp. So when we burp, air comes from the stomach into the esophagus, and then the muscle relaxes and it releases that air, and that's what a burp is. So that's retrograde, is in the opposite direction. Putting it all together, so it's a retrograde cricopharyngeus dysfunction, which means that when things are moving normally, as in swallow anterograde, it works fine most of the time, so it opens up, food goes down. But when things moving in the opposite direction, then it doesn't open, so it's a dysfunction. So it doesn't work when burping. Or RCPD is inability to burp, basically. So people who cannot burp.
Wow, that's something that you would never have thought of, but when you mention it, it sounds like a really, really frustrating thing to have.
It is, and this is because this condition has been first described as quite back in the 80s, but it wasn't widely recognized till the last 5 or 7 years, when it is picked up with the work of Dr. Bastian in Chicago, when he published his first paper on it. And it's a lot more common than we expect. Most people are not aware of it or never heard of it. So some people have lived all their life and they can never burp. And then they will have the symptoms, they have the pressure, etc. Air, it just goes into the esophagus, goes pressure, it doesn't release. And it is only because it started to get a recognition in the last few years, then more doctors became aware of it. And most importantly, patients became aware of it. Some people have these symptoms. They always thought, oh, this is me. This is what normal is like. And then only when they started looking into it that they started to realize that, no, that is not normal and shouldn't be the case. and there is help available.
Yeah, that's great to know. So what are the symptoms of RCPD, and how can they affect patients and their everyday lives?
So the main symptoms or inability to burp. So people cannot burp. So and that's often most people, you know, for as long as they can remember, they never burp. So it's in childhood. Normally, it presents in early adulthood or in a person teenage years. So from that time, they never burp. They don't remember they can burp. And what the symptoms are that you would expect, because a burp is the air goes from the stomach into the esophagus and then build pressure into the esophagus. So apart from inability to burp, then you will have this pressure in the chest and discomfort in the chest, just behind our chest bone. You will have that gurgling noises sometimes because this air goes up and then we swallow it again and it goes up and we swallow it again and give that typical gurgling noise. But also can affect further down, because if this air is not released through burping, it has to go through through the digestive system. So it can cause bloating, abdominal discomfort, passing gas, excessive passing gas. In some less common effect, it could cause hiccuping, because when the air comes into the esophagus, it distends the esophagus, so it causes irritation. So we start hiccuping. So these are the most common symptoms of it. How it impact people day-to-day life? Well, first of all, it can be like really uncomfortable. These symptoms. It can, like people can have that tightness in the chest, that pressure in the chest. They can have that after eating, especially after drinking carbonated water, because again, carbonated water or like all of the fizzy drinks will release gas. So every time they drink that, they will have like excessive symptoms, discomfort. So a lot of people avoid these drinks, so things that we do day to day. People will have, I can't drink fizzy water, I can't drink fizzy drinks, I can't drink a beer, because anything I drink in that regard will give me discomfort. So it can be embarrassing sometimes, like you are at work or at school or in a business meeting, and then you're having these gurgling noises coming out of your chest, which you can't control. Bloating, people feel, unwell if you're bloated all the time. Again, it's similar to like irritable bowel syndrome symptoms. So it can impact day-to-day life quite considerably in terms of quality of life.
Yeah, absolutely. It could just be, well, it's just a little thing, but at the same time, like you said, it's at work, social pressure, for example, if people like your colleagues want to go out for a drink or something like that, and you have to say no. Yeah, so yeah, absolutely. Okay, so let's see. What's the treatment approach for RCPD, and can patients require repeat treatment?
So to relieve that pressure, you need to allow this muscle to open. And the main way we do this for RCPD is by Botox injection. So I'm sure most of your listeners will be familiar with what Botox does. It relaxes the muscle, it paralyzes the muscle, temporary paralysis. So it's not permanent paralysis. So the main treatment for RCPD is Botox injection. So we go and we inject Botox into the muscle, directly into the muscle, and that will allow the muscle to relax and then allow that gas to come out. And we can do that treatment either under a short general anesthetic, because to get to the muscle, you either need to go through the mouth into the esophagus and you do the injection directly under direct vision, or you need to go through the neck and find the muscle and inject. And we can do that as well. You can't see, of course, if you're going through the neck, but we used alternative. So we use something called EMG, which is electromyography, which monitors the electrical activity in the muscle. So we know where the anatomy, we know where the muscle is. So you go with the needle into the muscle while you're connecting the patient, the needle to the EMG machine, and you will be looking at the trace, but also listening to the muscle electrical discharges. And once you think you are in the muscle, you ask a patient to swallow. You can give them a sip of water, and then you will see that the muscle relax, so it goes quiet, the machine, and then a muscle go into contraction again. That's what the normal swallowing function. So it goes like quiet and then disappear again. So you will have this very typical signal and sound ups associated when you are in the right spot. So you are in the right spot, and then you can inject your Botox. As a general rule, I have a preference of doing the injection under general anesthetic, under direct vision, because it's a lot more accurate, because you can see the muscle, you see the tip of your needle, you know where you are. And it is less potential for side effects because, again, you are more precise with your needle insertion. The problem with that, if you're doing it with the EMG, it's perfectly doable. And some of my colleagues will do that as their standard approach. I do it both ways. My preference is for theater, but I'm happy to do it under EMG. The problem with EMG, because it's not as precise, you will get the risk of that Botox spreading to the muscle around, which can affect breathing, it can affect the voice. So the tendency is when you're doing it with EMG guidance through the neck is you put a smaller dose, because you are, you want to be on the conservative side, make sure that you don't cause side effects. While if you're doing it with via under general anesthetic, then you can put higher dose because you are precisely in the muscle. The second part of your question is very, very interesting, actually. For those, most people are familiar with Botox mainly for cosmetic reason. Botox doesn't last forever. Botox is a 3-month treatment. So you inject Botox, muscle relax, wrinkles, etc. Or people who have medical condition like dystonia that require regular Botox injection to relax muscles that are in spasm, that you need to continue that 3-monthly, 4-monthly injection pretty much for life. With RCPD, it behaves generally different. So we inject with Botox. Possibly in the early report, it says around 90%, but I think now we got more experience. There is more publication. The percentage is possibly less. So in the 80s, so 80 something percent will have complete and permanent resolution of their symptoms after a single Botox injection. So you do one Botox injection, at least, possibly around 80% of people will be effectively cured from the condition. And we do not understand the mechanism exactly why this happened, because we know that Botox doesn't last. Like the Botox effect will wear off after 3 months, 4 months, say, at max. If you put in a higher dose and then you really obliterated all the muscle connection. But what we think is the theory behind it is you allow the brain to retrain and relearn how to deal with this sensation. So when we get that pressure, the air into the esophagus, and you get that distension, people with RCPD, their brain sensing that, there is pressure in the esophagus, let's close and just push this pressure down. While when you paralyze the muscle with the Botox, you allow that air to release. So it is in an effect relearning that releasing that air by burping is remove these symptoms of pressure. So we think that's the theory, that's how it works after a single injection. And we see that in 80% of people. So there is some mileage in that theory. So what happened for those 20% of patients? The majority will need a second injection with a higher dose. So maybe the first dose was not able to completely relax it. So we go back again, like a few months down the line, and then we repeat the injection with a higher dose and see how we go. And then there will be a small percentage of patients, like maybe 2-3%, but it just doesn't work. It requires like a repeated injection every 3 months, every 4 months. And then in that case, we need to take a step back and have that discussion with the patient about what do we do now? Do we keep coming? You can come back and have Botox injection every few months. People do that for dystonia, etc. You can do that for years and years. But again, it has an impact on somebody's quality of life. Are they going to have a general anesthetic every 3 months? Then that becomes impractical, because every general anesthetic will allow you need a couple of days to recover and all of that. Then maybe it will be more suitable to do that transcutaneously, like in injection in clinic for long term. And in very, very rare select cases, we can go and divide the cricopharyngeus muscle with a laser. That will be permanent, but also irreversible. So that decision needs to be very carefully taken to make sure that we can't put it back together if we divide it. So we need to make sure that we're doing it for the right reason. Patient is aware, we investigated, we are comfortable that we're not going to cause more harm long term.
Fantastic. That was such a really great in-depth answer. And patients need to be able to have all of that information to be able to consider what would be right for them.
Yeah, absolutely.
Yeah. And I'm absolutely fascinated to hear that the brain can relearn how else you how to tell. It's crazy. The human body is amazing.
Exactly. We have this neuroplasticity in the brain, and then it allows us, that's how we learn, that's how we adapt. It can, although, it does, in effect, it doesn't grow, but that learning continues. Some of it is conscious learning when we like actually studying, but also there is unconscious learning. Our body, our brain learn how to deal with these issue in our body.
Yeah, absolutely amazing. Okay, is there an adjustment period after treatment? And does it take time for burping to settle down?
Well, yes, there is an adjustment period. So going back to that learning, so in part of it and is we need to retrain the brain about this. So I actually tell my patients after the injection, normally Botox will take a few days to kick in, so to start working. So I tell my patient around 7 days after the procedure, start drinking fizzy water. So, and start practicing how to burp, so it just because, again, we need to teach the brain. So I get them like 3 times a day, drink some fizzy water, and then just practice burping. Most people would start with what they call micro burps. So it is start early, like small release of gas, and then they can, and then that gets better and better. And then we keep that training period maybe for like 3 weeks after surgery. And then we will say, now stop, and then go back to normal. You don't need to do anything. Some people will have like excessive burping after. You put the Botox, it relaxes, and it opens the floodgate basically. So they can start burping uncontrollably, which again, people need to be aware of, because that can be socially embarrassing as well. But that's the good thing with Botox, that it is, whatever it is in terms of like excessive burping or any of the side effects that can happen, is temporary, because Botox is temporary, so the physiological effect of Botox is temporary. So all of these effects, that extra effects that we see because of the Botox injection, will normally start to wear off after like 2-3 weeks, and things will start settling down.
Great. Okay, fantastic. And in regards to complications, I believe that swallowing issues can be a side effect of treatment. So does this require further treatment on top of?
The short answer is mostly no. So it can affect swallowing, and this is something that is very, very common. Actually, maybe half of the patient will have some difficulty swallowing after the operation. So that's something is to be expected, basically. So we counsel our patient that expect that you will have some swallowing difficulty. And that's because we relax the muscle, you paralyze the muscle, and that muscle is part of the swallowing mechanism. So people experience what's normally termed as a slow swallow. So, things are not passing this area quickly, and they need some adaptation. And most people adapt very well. And again, because most of our patients with RCPD are younger and healthy, on the young and healthy end of the spectrum, they can cope with these very well. Like a person with background swallowing difficulty, somebody in their more elderly, in their 70s and 80s, might struggle a lot more putting Botox, because their baseline swallowing function is already weaker. But for a young, healthy person, as most of our CPD patients, they cope with the swallowing issues quite well. And again, because it's Botox, it is temporary. So you will have that slow swallow initially for a period of few weeks time, 3 weeks, and then it start getting better. And at worst, it will last that 3 months. Does it require further treatment? It's unfortunately, once you put Botox in, you can't take it out. So you will have to wait it out. And most people on this extreme end of the spectrum, they will need some support. So we need to get people to see speech and language therapy to give them some advice, some dietary modification, sometimes modifying the position of the head when you swallow, avoiding certain texture that might be problematic, just for that bridging of that early period. But this is, again, within the context of RCPD, this is very, very rare that somebody will require speech and language therapy involvement, or as an extreme case, like a feeding tube for a little while, just to allow things to start working. Like if we do Botox for other conditions, somebody elderly, as I mentioned, Yes, potentially, but for RCPD patient, this is exceedingly unlikely. Other potential side effects is reflux and regurgitation, because that muscle, what part of it is to protect against reflux. When things come out of the stomach, it stops it coming out. So paralyzing it means that things can, so it can exacerbate symptoms of reflux. It can, in some people can, like food, if your reflux or stomach content can go up all the way to the throat. But again, that's not very common and it is temporary. So things get settled. The rest of the symptoms, like it affect breathing, etc., it's very, very unlikely.
Great. Well, thank you so much for clarifying. And it makes sense now what Botox does and the effects that it can have based on that. Really interesting. Okay. What are patients' reactions like after a successful treatment of RCPD, especially because, it could be quite a frustrating condition to have?
Um, it's delighted, I would say, most people, like this is one of the conditions that the most satisfying condition we treat, because people perceive it as like, like it's not a major condition, but for the person who's affected, it is a major day-to-day quality of life issue. And suddenly taking that burden away from people and allowing them to socialize and saving this discomfort. So most patients are delighted and very grateful, which means surgeon is very happy. If a patient is happy, surgeon is happy. Like you want to make a difference to the patient. It's something simple, a condition that somebody lived with all their life, and then they've had an injection. You see them 3 weeks later, and they were like, "I'm transformed. My symptoms are all gone." So it is very satisfying for the patient, and it's very satisfying for the surgeon as well.
Fantastic. Okay. In relation to swallowing disorders, I was wondering if you could briefly provide an overview of complex swallowing disorders, how they affect patient quality of life, and how ENT specialists like yourself assist in improving this.
Thank you very much. Yes, so I manage a lot more in the throat than RCPD. So this is one aspect of swallowing issues that I deal with. But I have in my practice, both in my NHS practice, but also my private practice, I have like a special interest in complex swallowing disorders. And swallowing disorders, or what we call scientific term as dysphagia, is something very common. And you see it as people get older, it becomes more and more common. It is estimated like in people who are hospitalized, could be up to 40% of people will have some swallowing issues. People with nursing home residents, it could be up to 70-80% of the population. So it's something very common, especially as we get older, especially the population is getting older and older because people are living longer. So we see these conditions a lot more. So we manage within our clinic, both, as I said, NHS and private, we manage the full spectrum of swallowing disorder. And to do this work, you need to work very closely with the speech and language therapy team. So we do this as a true partnership. So we have, for swallowing disorders, it depends on the cause for it. So the most common condition that we deal with in my practice is neurological dysphagia, people who had strokes, had some neurological event, sometimes traumatic brain injury, etc. So that can affect their swallowing. We deal with a lot of patients that have other neurological condition, Parkinson's disease, other neurological condition that can affect swallowing, motor neuron disease or such. We manage a lot of patients after head and neck cancer treatment. So people with head and neck cancer, they receive surgery, which is quite aggressive surgery to their throat and neck, but also they receive radiotherapy, and then which cures their cancer. But when you look again, because we can cure a lot more cancer now, people are living longer. So we started to see a lot more of what we call a late effect of radiotherapy. So that's normally happened for cancer survivors 10, 15 years after radiotherapy. When you start seeing these late effect of radiotherapy, the tissue itself becomes replaced with a scar tissue, the muscles start withering away, the nerves start to develop neuropathy, so it's not working as much. So we have big cohort of our patients are these late effect radiotherapy patients who survive their cancer, and now 10, 15 years later, their swallowing becomes really problematic, so we deal with these. And then we have the patients who have what we call presbyphagia, which is swallowing difficulty in the elderly as well, which again we're seeing a lot more. And it depends on the condition, then we can tailor our treatment. We normally need comprehensive swallowing evaluation. So this is something we do between myself and my speech and language therapy colleague. We run often a joint clinic, joint dysphagia clinic, joint swallowing evaluation clinic. So the two main things we have are one called endoscopic swallowing evaluation. You put a camera down, you're taking a look, and then you get the patient to swallow, and you watch them swallow, and you see what's happening to that food and liquid, how it's passing, is it holding, is it not passing, going into the windpipe. But you can do it also as a video fluoroscopy, which is something we do with X-ray. So you give something to drink and you take X-ray, so it is like a X-ray dye, and then you will see how that moving down. And there are more modern technique that I have access to, high resolution manometry, which looks at the muscle pressure, etc. So we have like a comprehensive set of tests that we can do for the patient, and then we tailor our approach depending on that. If there is something that surgical intervention can work in, again, sometimes if the muscle is not relaxing, you can put a balloon and stretch it. You can divide with the laser, put Botox. Sometimes airway protection is an issue, so people, food and water going down the wrong way. Then if there is vocal cord paralysis, we can do an injection to try to close that gap and offer more protection to the airway. But a lot of what we do is swallowing rehabilitation, and that working with a speech and language therapy, either by modifying diet, modifying head position compensatory technique, or actually physiotherapy to the throat, exercises to make the muscle stronger and coordinated better. So it's a massive subject. So I tried to sum it up in like 2-3 minutes. So I hope that was reasonable.
It was perfect. That was really, really good. Yeah, absolutely. Not too overwhelming, but also really informative, definitely. Okay, fantastic. Well, thank you so much for joining us today. It's been really interesting to hear all about it, all about RCPD and the swallowing disorders. Really interesting.
Thank you very much. Thank you for having me. And just a word to the patient. These stuff are common, and a lot of people don't realize. They think that this is normal. This is me. I'm just getting older, or I can't burp. So, but no, there is help available. There is always support available. So do reach out to myself or to my colleague who are within this field. There is a lot that we can offer between us and between speech and language therapy to improve people's quality of life. So do reach out if you're suffering with any of these symptoms.
Absolutely. Okay, so if you're considering treatment for RCPD, arrange a consultation with Mr Al Yaghchi via his profile at topdoctors.co.uk.
Thank you very much, Caroline.
Thank you.